Good evening, everyone, and good morning if you're joining us from another part of the world. This is the 20th of January. I think you're going to have the best January evening you've had so far. And that's because of the talk we are going to have in a bit by Dr. Melody Asukile. Melody is a Zambian neurologist and president of the Zambia League Against Epilepsy, which is a local ILAE chapter. She directs the EEG laboratory at the University Teaching Hospital in Lusaka and is pursuing a PhD at University College London, focusing on improving epilepsy diagnostic pathways and management in resource-limited settings. Her research interests include EEG education and the use of telemedicine for neurology. So she's just the right person to take us through today's talk on EEG and Coma. Welcome very much, Melody, and welcome everyone.
Thank you, Sam, for the kind introduction, and welcome everyone. It's such an honor to be invited as usual to share some knowledge about EEG and also to learn from each other. I'll just share my slides. Okay. Hopefully you can see those. And let me try. All right. Okay, so today we're going to talk about EEG and coma. As many of you may be familiar with EEG, you will agree with me that this is quite an extensive topic. And so what I'm going to do today is really try to give an overview about some key characteristic features that we see in people in coma having an EEG, and also really what are the clinical implications of those findings. So the only disclosure I have is that a lot of the EEG examples you see in this talk are from a course on which I'm a tutor, which is called EEG Online. And you're all welcome to register for this course. This is a brief outline of some of the things I will discuss today, starting with a brief introduction about EEG, and then looking about the different ways we analyze an EEG in persons with altered mental state, and then delving a bit into the different characteristics that we'll expect. I think it's important to note that this talk will not talk about epilepsy and seizures specifically, and so we'll focus really on the EEG in a person with an altered mental state or a depressed level of consciousness. So just a brief background, what is EEG? So EEG stands for electroencephalogram, and an EEG is a record of the electrical activity in the brain. So the commonest type of EEG that we use is the scalp EEG, which measures activity on the brain surface using small metal plates as depicted on this picture, connected by wires. These wires are then connected to a device called an amplifier, which generates a digital recording, similar to what you'd see in an electrocardiogram, but this time we're seeing activity of the brain in form of waves. So there's different types of EEG, but for the purpose of this talk and thinking about EEG and coma specifically, we most often use a scalp EEG. The goal of the EEG again is to try and assess the activity of the brain from as much of the different areas as we can. So that's thinking about the frontal parts of the brain, the parietal, the temporal, and the occipital. And so in that regard, electrodes are placed across the scalp surface to try and cover all these different areas. There are different types of electrode placement. So where we place these signal pickups or the metal plates, the commonest one, especially in routine EEG, is what we call the 10-20 system. And this is just essentially the system of how electrodes are placed on the brain. This is an example of what an EEG will look like. And this is a typical recording of an EEG. And so what you notice is that whenever we're recording an EEG, we read the signals depending on different relationships of the different electrodes placed on the scalp. One of the commonest ways we read is where we look at one electrode in reference to another. And so this is the way the electrodes are arranged and the way they are read. Those are called montages. So this is a common montage we call the longitudinal bipolar montage. And we read the parasagittal channels, we read the temporal channels, and the midline channels. And so these are arranged, as you can see on the left of the screen, with firstly the parasagittal channels, frontal, central, parietal, occipital. That's the letters stand for the region. Odd numbers refer to the left side of the brain, even numbers refer to the right. And so you can see if it's T, that stands for temporal, and so on and so forth. So this one just shows us a typical snapshot of a normal EEG. Another thing to appreciate is that on this EEG, you have these vertical lines, quite faint, but each vertical line represents 1 second. And so when we talk about the frequency of the waves, we look at how many bumps do we see in 1 second. And so for here, example, you see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So about 10 and a half waves per second, and that tells us that's a normal background rhythm. So what is the role of EEG in altered mental state? So EEG is valuable, as we know, in supporting the diagnosis of epilepsy. So when we think about epilepsy, it helps us determine if there are any epileptiform discharges, what are called interictal epileptiform discharges, and whether the discharges tell us if the epilepsy is focal or generalized. Though EEG is very helpful when it's abnormal, it's important to note that because of its low sensitivity, which can be as low as 50%, a normal EEG does not necessarily exclude epilepsy. When we think about people presenting with an altered mental state or a depressed level of consciousness, the role of the EEG is firstly to determine if there is encephalopathy, which is a non-specific general dysfunction of the brain. And this is very often important in explained depressed level of consciousness. Sometimes it might also be useful in patients presenting with psychosis, where a pure psychiatric type of illness would have a normal EEG, as opposed to a psychosis in the context of encephalopathy, where the EEG will be abnormal. Further, we want to tell if this non-specific dysfunction is focal, is it occurring in one particular area of the brain, or is it affecting the whole brain? Further, apart from just saying if there's encephalopathy, we want to determine the degree and severity of this dysfunction. Sometimes we might not know if this altered mental state is because someone is having seizures or not. And so it helps us see if there's an increased risk for seizures or if indeed there is ongoing active seizure activity, what we would call non-convulsive status epilepticus or subclinical seizures. So whenever we begin thinking about using an EEG for assessment of encephalopathy, we must always start with an assessment of the background activity. And with the background activity, the American Clinical Neurology Society, or the ACNS, provided guidelines on what features to look at when you're assessing the background. And so it always starts with thinking about the symmetry. So is the left the same as the right? And this is in terms of the voltage, how high the waves are, and in terms of the frequency, how fast the waves are. What is the predominant background when the person is most awake or after stimulation? Is there a normal posterior dominant rhythm? This is also called the alpha rhythm, and I showed you the picture of that earlier. I'll talk more about the frequencies. Is the background continuous? So are the waveforms always present, or are there gaps in which there is reduced or no activity? Is there reactivity? That is, when you see a background and you offer a stimulation. This can include opening or closing eyes, verbal, tactile, or painful stimulation, and you need to see a change in the background activity for you to say that the background is reactive. Are there any changes of state, say from alertness to drowsiness or sleep? Are there features suggestive of encephalopathy, which is the dysfunction that we're talking about? What is the voltage? And the voltage is synonymous with the amplitude. So is it high amplitude waves? Are they low amplitude or medium? Is there a normal distribution of waveforms between the front and the back of the head? And what you normally find is the back of the head, you tend to have slower waveforms as opposed to the front where they tend to be faster. Has there been a switch in this gradient? Is there evidence that there could be a defect in the skull? This can happen, say, in previous trauma, if there's been a craniotomy or a burr hole, and you'll find that the rhythms in that area will be accentuated and they'll show faster rhythms, what's called a breach effect. So it's important as you start with the assessment of encephalopathy to think about all these aspects of the background. So now let's start talking about general slowing of the background. So a normal awake background typically comprises a posterior or occipital predominant alpha rhythm. An alpha rhythm is said to range from 8 to 13 hertz. Hertz essentially means per second, so 8 to 13 means 8 to 13 waves per second. This is a schematic which is just demonstrating that if you have the 1 second, in that 1 second space, if there are 8 waves or up to 13, then we call that alpha. We might also see beta activity, which is faster, 14 to 30 hertz, and it is considered normal in both wakefulness and may be present in sleep. So we start talking about slowing when we see theta, which is 4 to 7 waves per second, hertz, or delta, which is less than 3.5 hertz. So these are consistent with background slowing. However, it's important to note that they can be both normal and abnormal depending on the context. So when you are thinking about background slowing, we need to take note of the age of the patient because the younger the patient is, the slower their frequencies will be, especially in children less than 2 and in neonates. We need to think about the level of alertness. If someone is drowsy or asleep, these may be normal waveforms. Think about things like lateralization. Are these slow transients or slow waveforms in one particular area of the brain as opposed to the whole brain? How persistent are they? Are they coming and going, which is typical of drowsiness, or are they throughout the recording? And is there reactivity, which is a key component in that if, say, someone is asleep and they've got slowing, if you wake them up, their background should react and it should go back to normal. So absence of reactivity, for example, can hint to you that this slowing is abnormal. So what are causes of abnormal background slowing? So several of us may come across an EEG report where we may say that the EEG is abnormal because there is abnormal slowing of the background. And when we hear this, this is really non-specific, and there are many possibilities why someone might have background slowing, or sometimes we might say they have an encephalopathy. This can be because of metabolic issues like electrolyte derangements, hypoglycemia, hypoxemia. It can be because of diffuse traumatic brain injury. It can occur in a post-ictal state, so just after a seizure or seizures. If it could be because of an encephalitis, which can be infectious or autoimmune, commonly can be results from drugs and toxins, and even further on, it can be due to underlying genetic or developmental abnormalities. So noting slowing of the background tells us there is a problem, but it really does not tell us what the problem is, and we'll need to look further, look at the clinical picture, look at ancillary tests to determine what has caused this abnormal background slowing. So I'll start by looking at some of the types of slowing that we might see. So theta slowing, as I mentioned in the other slide, theta is a frequency of 4 to 7 hertz, or more accurately 4 to less than 8 hertz. Generally, theta indicates a less severe abnormality than delta slowing, for example. And further within the theta band, 6 to 7 hertz theta, which is faster than 4 to 5 hertz theta, suggests that there is mild encephalopathy if it's 6 to 7, and it's more severe if it's 4 to 5. Again, if it's focal, it tells us that there's a focal lesion versus if it's generalized. But as mentioned again, the cause is non-specific, and it may represent a structural lesion or a transient reversible dysfunction. So what you see on this epoch, that's what we call an EEG snapshot, an epoch. Again, you see we have settings there. We've got the even numbers, so that's right parasagittal, left parasagittal. Then we've got right temporal and left temporal. And this is our ECG recording. So if you look between the two yellow lines and you count the bumps here, you see there's 1, 2, 3, 4, 5, 6. So 6 to 6.5. That tells us that it's a theta and it's on the faster side of theta. So we'd call it mild. What you notice though is there are these positive deflections on both sides at the front of the head. These represent eye blinks. So meaning this patient is awake and they are blinking their eyes, but we just see a persistent theta background. So this is telling us that in someone who's wide awake, but we are not seeing what we would expect to be a normal alpha background, this is suggestive of some form of abnormality. Of course, we'll need more information and look at more epochs, but from this one snapshot, this would be concerning for us, that if they are blinking their eyes and they're awake, we should be seeing a normal posterior dominant rhythm, which we're not. And so this could suggest a mild encephalopathy. In delta slowing, this describes slower waveforms with a frequency of less than 4 Hz. Delta is often described in two forms, and these could occur independently or they could occur concurrently in the same recording. So delta can be polymorphic delta activity, and this is where delta waves are of varying duration, and sometimes they can be called arrhythmic or irregular. This pattern may be normal in non-rapid eye movement sleep, or it may be abnormal. And as mentioned earlier, again, it could be focal or generalized. And then we've got what we call rhythmic delta activity. Here, the delta waves occur in bilateral, symmetrical, bisynchronous patterns, and they are rhythmical and monomorphic. They often occur in runs and last a few seconds. Often with the rhythmic delta activity, we describe them based on their location. So if they are frontal predominant, we call that FIRDA, frontal intermittent rhythmic delta activity. If it's occipital, OIDA, occipital intermittent rhythmic delta activity. But sometimes it might also be just generalized rhythmic delta activity. Often these waveforms are non-specific, with the exception of one, which is a temporal intermittent rhythmic delta activity, which tends to be closely associated with temporal lobe epilepsy. So here are some examples of polymorphic delta activity. And here we can see that we are seeing these delta waves, which are not, they are all over the place, not really in a nice rhythmic fashion, but it's continuous. There are no breaks in our waveforms. And indeed, we can also see that there's some theta within this delta activity. So because there's some faster rhythms and slower rhythms, this type of slowing is milder than one where there would just be pure delta, for example. We also note that an annotation has been made of mental alerting. So this is trying to stimulate the patient in one way or another. We're not told how. But what you notice with stimulation, both before and after the stimulation, there is no change in the background. And so this tells us that it has a higher degree of severity as opposed to if we noticed a change. So delta slowing can also be focal. Previously, I showed you generalized polymorphic delta. If you can appreciate here that just at a glance, if you look at right and left, there seems to be a difference. And so what you notice is that actually this delta slowing seems more so on the left hemispheric leads than the right. And so this suggests that there should be some left hemisphere abnormality. This could be structural, it could be inflammatory, it could be hemorrhagic. We don't know. All we can say at this point is something is wrong in the left hemisphere more than on the right. Even the right is not abnormal, but the left is worse than the right. And again, here there is mental alerting, and it looks like they were doing verbal stimulation, asking the patient questions, and we see no reactivity to mental alerting. And then we can have the rhythmic delta slowing. So what you see here now is these like waveforms in a pattern forming a rhythm like bump, 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 bump. And again, we appreciate that in this situation, the F, if you see F is frontal, so the slowing seems to be more in the F leads, the frontal leads. And it's for a few seconds, 1, 2, 3, 4, and then it goes back to just some theta slowing. And so this is typically what you would see in frontal intermittent rhythmic delta activity. And it often occurs in the setting of an already slow background. So this patient already has a slow theta, about 7 Hz theta background, and then gets these intermittent runs of rhythmic delta. Further, which is frontal intermittent rhythmic delta activity, it's often non-specific. It may suggest just non-specific generalized dysfunction, but it may also be seen in situations of what we call a projected rhythm. So if there's a deep midline lesion, for example, we might see further being projected to the surface. Or if there's raised intracranial pressure, that might also be another situation where a further rhythm is produced. But in general terms, it is a non-specific finding of encephalopathy. So those were types of slowing of the background and thinking more just general background slowing. However, when there are patients in coma, there are some distinctive patterns that we might look out for. And these are characteristic of people with an altered mental state. So the first one we'll talk about are triphasic waves. So triphasic waves are characterized by a large positive wave preceded and followed by smaller negative waves. So it's called triphasic because it has 3 parts or 3 wave components to it. So you can see there is this small negative wave, a big positive, negative is up, positive is down, and then another smallish negative wave. And what you note and what's characteristic of a triphasic wave is that each wave progressively increases in duration. So it will be short duration, longer, and much longer duration. And that's what characterizes a triphasic wave. They often occur in runs, and during the run, there will be no intervening background activity, but at times they might also occur individually. They tend to be biggest in the front, so they tend to be frontal predominant, but occasionally they can be occipital predominant as well. And also sometimes you might note that there's a left to right type of shift as you go down the EEG. Triphasic waves as well are a non-specific abnormality, but observational studies have noted that they tend to be most commonly seen in those with toxic metabolic encephalopathies and even specifically in hepatic encephalopathy. Despite them looking quite sharp and pointed as we would see in epileptiform discharges, they are typically not associated with seizures in their true form. Another pattern that's quite distinct of coma is what's called the burst suppression pattern. So the burst suppression pattern consists of bursts of cortical activity interspersed with periods of marked attenuation. So what you see is this sudden cortical activity that's called a burst. And then you see this period where there's little to no activity and then followed by another burst. So the morphology and duration of each burst tends to vary quite considerably. So this will not be exactly like this and will not be exactly like that. And the interburst duration also varies quite considerably. So like you've seen, this period is much shorter than that one, for example. It is often seen in severe encephalopathy, so in anoxic brain injury, severe hypothermia, in late-stage convulsive status epilepticus. However, burst suppression can also be medically induced, say, for example, with deep anesthesia. So as severity increases in the encephalopathy, what you'll find that over time, there will be fewer bursts, which is fewer cortical activity periods, and longer suppressions. And it may then get to a time when there's no activity at all, when there's complete generalized suppression. So determining whether a burst suppression pattern is very bad or not so bad really comes down to what was the cause. So if it's due to anesthesia, this is potentially reversible. However, if you're seeing a burst suppression pattern in the context of a cardiac arrest, and with resultant anoxia and ischemia, it often has a very poor prognosis. And then finally, as I mentioned, from burst suppression, you can end up with suppression. And this is where the voltage of the waves is markedly attenuated. So suppression is defined as no consistent waveform over 10 microvolts in amplitude. So with many EEGs, you can actually measure the amplitude of the waves. It's important to note that you need to check what sensitivity you're using. So the higher the sensitivity, meaning if this number is 2 microvolts per millimeter, for example, that helps us see the waves bigger. And the bigger the number here, the smaller the waves will appear. So at standard settings, which is from 5 microvolts per millimeter to 10 microvolts per millimeter, if you're seeing a really flat signal like this, it's telling you the voltage is very low. You increase the sensitivity up to 5 or to 2 to see if these waves can be bigger, and you measure how tall the waves are. And if they are less than 10 microvolts, we say that there is suppression. It's important as well, a technical thing to note is that when we're measuring suppression, the type of montage, which is the way we look at the electrodes in reference to each other, is very important. And here we say that it's important to use a referential montage. Referential montages are various types, but these allow us to look at each point further away from another point. With the EEG, it's all about measuring potential differences. So the further away you are, the bigger the chance that you can detect a potential difference. And measuring, like this is a longitudinal bipolar montage, there's a high risk of cancellation effects, which could suggest suppression when there isn't. So using a correct referential montage, using high sensitivity, and you still find very low amplitude, then we say there is suppression. And suppression implies that there is severe cerebral abnormality and there is insufficient function of neurons to provide a normal amplitude. The prognosis again of suppression will depend on what caused it in the first place. So another feature that we look out for are rhythmic and periodic patterns. So according to the ACNS, again, rhythmic and periodic patterns are described in two main forms. And so they use the main term one, which talks about the localization. So where are these patterns? Are they generalized, lateralized, bilateral independent, meaning they're on both sides of the brain but occurring at different times, or they're in multiple areas of the brain? Then there's a new term, unilateral independent, where it's on the same side of the brain, like it's both on the right, but say the frontal ones are occurring different from the temporal ones, for example. And then once you determine the localization, you want to say what type of waveforms they are. Are they periodic discharges? Is it rhythmic delta activity, which we touched on just in the previous slides? Or are they epileptiform discharges, which is spike or polyspike and wave, or sharp and wave? So we'll start by thinking about periodic discharges. We did talk briefly about the localization, so I won't go too much into those details, but essentially it just describes where the problems are or the abnormalities are. In periodic discharges, there is a repetition of a waveform with a relatively uniform morphology and duration, with a clearly discernible interdischarge interval between waveforms and recurrence of the waveform at nearly regular intervals. So this is in contrast to the burst. The burst, there is no clearly discernible interdischarge interval. You can't say it's happening every 1 to 2 seconds. It can be 1 second, it can be 3 seconds. But if you are going to call it periodic, that distance is almost always the same or close. It's not exactly the same, but it's close. There should be less than a 50% difference in terms of the intervals. the waveforms look very similar. Again, in contrast to the bursts, where the waveforms, each time there's a burst, it's different. In periodic discharges, it looks almost always the same. And then, so that's saying if something is periodic. The next thing is if we're calling it a discharge. So to call it a discharge, it should last less than 0.5 seconds, regardless of number of phases. Or if it's more than 0.5 seconds, it should have less than 3 phases. All these are really to help us distinguish a burst from a periodic discharge. So we'll start with generalized periodic discharges. So as you can see on this slide or epoch, you have these waveforms that are coming every, maybe we would say this is 1 second, half to 1 second. But that space, that space, that space, that space, that space, they are around the same. And you see this burst, very similar to that one, very similar to that one. As I mentioned, this is 1 second, and this would be half a second. So this burst is less than half a second. So it's occurring relatively regularly. The distance in between the bursts is similar. The bursts themselves are similar. And so these would be called periodic discharges. This is, again, right parasagittal, left parasagittal, right temporal, left temporal. And so it's happening essentially throughout the brain. Maybe not so much in this right anterior temporal, but you could still see some abnormal discharges there. So this GPD suggests an acute to subacute destructive pathology. And we usually think about them in terms of the interval period. So there's short interval or short cycle GPDs, which are 0.5 to 4 seconds interval distance. And they are commonly associated with stroke, tumors, infection, and you can also see them in certain neurodegenerative conditions like CJD. And then one characteristic type of GPDs are the long interval or long cycle GPDs. And these can be up to 30 seconds in terms of interval. And to see that, you would need to actually increase your paper speed. So here we are seeing 10 seconds on one page. We would need to maybe see 30 seconds on a page or 60 for us to see a 30-second interdischarge interval. And when we see that in a person with coma, it's highly suggestive of that long-term complication of measles, subacute sclerosing panencephalitis, or SSPE. And then we can have lateralized periodic discharges. And so lateralized periodic discharges, as the name suggests, are occurring more on one side of the brain than the other. In this epoch, we can see that the right side of the brain seems to have these discharges with relative sparing of the left. And so again, there's similar discharge morphology and interdischarge interval. As you can see, this one looks a lot like that one, which looks like that one, and this space looks very similar. The discharges are often sharp, but they are not necessarily associated with seizures. And that's why in the past, these actually used to be called periodic lateralized epileptiform discharges. But it was noted that it's not always that you see them, that there's epilepsy or seizures. And so then the term LPDs was adopted. They often do suggest an underlying focal destructive lesion, like a focal encephalitis. So you typically see them, for example, in a herpes encephalitis, we would see temporal LPDs. They can be seen in subdural hematoma or intracerebral hemorrhage. If there are features, they can be features that do suggest seizure. For example, evolution, increasing frequency, and so on. But in their true context, they will just suggest that there is a destructive lesion. That does suggest that there is an increased risk for seizures given the destructive lesion that's present, but they do not in themselves signify ongoing seizure activity. And then different neurophysiologic societies and neurology societies, they've described these entities, and this is just one example of waveforms that are found in what's called the ictal-interictal continuum. So the space between determining whether someone is having seizures or they are not. And that's now called the IIC, the ictal-interictal continuum. So this is one example of those things that are in that border between seizures and not. These are called BIRDs, brief potentially ictorhythmic discharges. So in birds, they have a frequency of more than 4 hertz, so they are in the theta range or above, and they last from more than half a second, but to less than 10 seconds. So they can be just rhythmic theta, or they can actually have epileptiform morphology. Like here we see it's spike and slow, spike and slow. What we see in a spike and slow wave is an epileptiform discharge, but it's not lasting more than 10 seconds. So, and they also tend to have an evolving rhythm. If we were talking about seizures today, we would know that evolving rhythms are characteristic of an electrographic seizure. But in these, they are not meeting that criteria because they are less than 10 seconds. However, they are associated with a higher risk for seizures. We typically see them in those who are critically ill, and they may be useful in predicting the seizure onset zone in those EEG recordings where this is not clearly defined. And as I mentioned, they fall in this gap or interspace between ictus, which is seizure, and interictal, which is not seizure. But it is a marked abnormality, and it does suggest an increased risk for seizures when present. Then spike and wave or sharp and wave. So spike, polyspike, sharp wave, consistently followed by a slow wave in a regularly repeating and alternating pattern with a consistent relationship between the spike component and the slow wave for at least 6 consecutive cycles. So when we see that, then we call it a spike wave pattern, and there should be no interval between one spike and the next. I think it's important to note as well that as we discuss all these different things, a lot of times they become very particular because we think about them in terms of research, for example, in terms of how do you classify one person from another. And indeed, they do also play a role in the clinical decisions we make. But a lot of times it does fall down to the question of, is someone having seizures right now, or are they at risk for seizures? Or is it just another abnormality? So it's really in 3 pockets, and many of these, though there are lots of overlaps, can help us answer those 3 questions. So if there is an interval, they'll be called PDs, as opposed to if there's no interval, then they are more like sporadic epileptiform discharges. So this is what you would see. This is a type of pattern where you've got a sharp spike followed by a slow wave. And you can see that it's going spike and wave, spike and wave. 1, 2, 3, 4, 5. It's about 5.5 seconds. So hasn't reached 10 seconds yet, but we can see that we have that morphology. There is no gap in between each discharge, so it wouldn't fit to be called a periodic discharge. And this would be more suggestive of, for example, an interictal epileptiform discharge. So then when do we say that someone's having seizures? So we think about seizures in the comatose state as electrographic or electroclinical seizures. So the commonest question in a person with an explained depressed level of consciousness is, are they having subclinical seizures, or do they have non-convulsive status epilepticus? So according to the ILAE, non-convulsive status epilepticus is status epilepticus with no prominent motor features lasting more than 10 minutes. So essentially, this is a person who has unexplained depressed level of consciousness, no overt signs that they're having seizures, so they're not convulsing, they're not twitching, but you highly suspect that their brain has seizure activity. And really, the only way to definitively answer this question is through EEG. A study that was once done in our country, Zambia, this was an EEG-based study of 250 patients with a GCS of less than 10 on a 30-minute EEG. I bring this up because many of our countries do not have access to continuous EEG monitoring. So a routine EEG was done for 30 minutes, and they found that in this group, 28.4% had epileptiform abnormalities. About 8% met the criteria using the SYNEX score for non-convulsive status epilepticus. There was about 1% with subclinical seizures, and double that, about 16% with interictal epileptiform discharges. When we think about the prevalence or the incidence of non-convulsive status epilepticus, it really has a wide range occurrence from different studies, ranging from as low as 5%, 48%, depending on the cohort that is being observed. So it can be quite common in people presenting with unexplained depressed level of consciousness. So according to the ACNS, electrographic seizure is defined as either epileptiform discharges averaging more than 2.5 hertz, so more than 2.5 waves per second for more than or equal to 10 seconds. Or in other words, if you look at a 10-second space, there is more than 25 discharges in that space. So that's one that we would call it an electrographic seizure. The other time we'd call it an electrographic seizure if there is any pattern with definite evolution and it's lasting more than or equal to 10 seconds. So evolution is when there is a change in the frequency and the change in the amplitude over a period of time, and there's specific ACNS criteria for that. But if there is evidence of evolution, we call any pattern, so whether it's just rhythmic slowing without the sharp components, or it is the spike and wave components lasting for more than 10 seconds. And that's why if you saw this all ties in together. So birds, because they are less than 10 seconds, they don't fit as seizures. Epileptiform discharges, which don't last 10 seconds, will not fall as seizures. So it has to be 10 seconds for us to call it a seizure, and then it depends on what it looks like. We then call it electrographic status epilepticus if these abnormalities are now going on for more than 10 continuous minutes. So if you've seen those abnormalities described above and they are just lasting ongoing for 10 minutes, or if in a 60-minute recording, you can have up to 20% of that recording. So essentially, when you total all these abnormalities, they are lasting 12 minutes of a 60-minute recording. Then again, we can call it electrographic status epilepticus. So as you can see, it gets quite technical, but one thing I would say is, if you see one seizure, one 10-second seizure, versus if you see the true definition of status, even the one seizure in an hour, the risk of status epilepticus is very high in this comatose patient. So very important for really splitting hairs, but seeing seizures is a big concern. So this is just an example of how an electrographic seizure would look. And this is satisfying that second criteria of an evolving rhythm. So you see here in the right temporal, these sharp, slow components, they start. You see them in the right frontal, then they go to the left, and it's evolving. They are getting bigger with time, and they are getting faster with time. So there's an evolution in amplitude, there's an evolution in frequency, and it's starting from the right. An electroclinical seizure are very similar to an electrographic seizure. The only difference is this time we have some form of clinical correlate that we can time lock to the pattern. So during the time we're seeing that abnormal pattern, we are also seeing some clinical features. Maybe there is dilation and constriction of the pupils. Maybe there's some subtle twitching. The other way we can diagnose an electroclinical seizure is retrospectively. So if you see you have this patient in coma and then you have a rhythm that's very suspicious for a seizure, and we give anti-seizure medication, typically IV medication, and you see an EEG and clinical improvement, then we can retrospectively say that was an electroclinical seizure. So electroclinical status is the same as electrographic seizure, Just that in this scenario, we've added the clinical manifestation, but it's still the same, continuous for 10 minutes or more than 12 minutes in a 60-minute period. It's important to note that if you've got prominent clinical features, so if you've got prominent bilateral tonic activity, that is no longer non-convulsive status epilepticus. That is just convulsive status epilepticus. And so the time limits remain the 5 minutes. Also, important to note that there is again this an area of uncertainty, what we would call possible electroclinical status epilepticus. And this is where you give your anti-seizure medication, the EEG improves, but there is no clinical improvement after anti-seizure medication. The caveat here is when you're treating non-convulsive status epilepticus, it's different from convulsive status where you're expecting almost immediate responses. In non-convulsive status epilepticus, response to anti-seizure medication can be delayed. In adults, it's thought to be delayed even up 6 to 12 hours. And so you do need, if you've given what you believe to be adequate medication, and if, say, you've seen an EEG improvement, do give up to about 12 hours of observation before you say there is no clinical improvement, because the clinical improvement might come much later after EEG improvement. So, several investigators recognize the fact that the best way to diagnose non-convulsive status epilepticus or subclinical seizures is through continuous EEG monitoring. So this is where you've got a patient in ICU, they are hooked up to the EEG machine and you're monitoring them for 24 hours in a day. However, many of us do not have access to continuous EEG monitoring. And so a score was developed to help us predict the risk of seizure recurrence in EEG recordings that are less than 1 hour. So if we record EEGs for 1 hour, can we predict which type of patient is likely to have more seizures, and such would be the one you would recommend for continuous EEG? So say maybe you do have continuous EEG, but it's limited. In which type of patient would you say, this one I'll recommend longer term versus this one I would not? In our setting, really, it would help us to say, okay, based on this score, this patient is more likely to have more seizures, and maybe I'll treat them empirically compared to this one who has a lower score. So this score is called the 2 helps 2B score, and it's a predominantly EEG-based score, but it also has one clinical feature. So it has 5 EEG features and one clinical feature. The EEG features being if the discharges have a frequency of more than 2 hertz, as we described, more than 2 cycles per second is concerning for seizure. If there are independent sporadic epileptiform discharges, so aside from like a rhythmic discharge, maybe you have just every now and again epileptiform discharges. If you've got lateral periodic discharges or bilateral independent periodic discharges or lateralized rhythmic delta activity, if there is superimposed rhythmic, fast or sharp activity on all these other discharges, if there is history of a seizure, which is recent, or even history of epilepsy, and if you remember the birds that we talked about, so if those are present. So this scoring helps us to stratify that risk for seizures. With the lower score, the total score is 7. So a lower score suggesting a lower risk for seizures, and a higher score suggesting a very high risk. So you could stratify these into determining who you think you'll put on CEG, or in other terms, who you are more likely to treat with anti-seizure medication empirically. So this score can be quite helpful in that setting, and it's typically done in EEG recordings of less than an hour. They do recommend at least an hour, I think that's what was used in these studies. And then from that, you can use the score to stratify your patients. Finally, I want us to discuss a little bit about EEG in brain death. So EEG in brain death, the controversy in the definite diagnosis of, there is controversy in the definite diagnosis of brain death. The use of EEG to support diagnosis of brain death must adhere to strict guidelines. And it's important to note that it should not substitute a thorough neurological examination. Many times, as neurologists, we are called to diagnose brain death, but we shouldn't just use an EEG. It really has to be carefully thought. According to the ACNS, brain death is described as electrocerebral inactivity. And this is where there is absence of non-artifactual electroactivity over 2 microvolts when recording from scalp electrode pairs 10 or more centimeters apart, when the recording is performed in compliance with certain standards. And so there are quite rigorous rules on how the EEG should be recorded if you're going to use it for brain death assessment. There should be a complete complement of scalp electrodes, so it should be quite like the 10-20 system I showed you or the 10-10 system. You have to make sure that there's very minimal electrode resistance. You have to check that each electrode is tested and is working. Then when we are doing ECI interpretation, electrocerebral inactivity, we often want to use far inter-electrode distances, so like a referential montage or even skipping between electrodes. So usually in the bipolar electrodes are maybe about 5 centimeters apart. So you may want to skip so that you get that 10 centimeters. The sensitivity must be increased to the maximum. The lower number, the higher the sensitivity. You have to record for at least 30 minutes. You need to ensure the filters are appropriately set because high filtering can mimic a suppressed EEG. You should look out for different artifacts that may be present. And there must be no reactivity to intense stimulation. So this should be different from somatosensory, auditory, visual. The recording has to be performed by someone who's experienced and qualified in performing this type of EEG. And if it's unclear or it's in doubt, the EEG should be repeated. So as I mentioned last time, adults, there can be a delayed response of up to 6 hours. In neonates and children, this can even be longer. So they recommend if you're going to repeat, it should be after 24 hours. Make sure that you've recorded all the possible physiologic variables and medications that could impact on the EEG, including presence of hypoxemia, hypothermia, hypotension, and drugs. So it must be a rigorous process, even when we use the EEG, if we feel that it's something that can help us support the diagnosis of brain death. And so just some take-home points. EEG is a useful ancillary test for the assessment of the severity, type, and cause of coma. A thorough clinical assessment and technically sound recording is essential to avoid erroneous reporting of abnormalities. EEG is very prone to artifacts, is very prone to error, and so we must make sure that everything is done correctly if we're going to trust the findings. Coma can reveal non-specific abnormalities that are focal or generalized, or it can reveal evidence of current or proposed or possible future seizure activity. Important to note that just like brain activity, the EEG is often volatile, and so a repeat recording may be needed before you reach a conclusion. However, as we say over and over again for anyone who reads EEGs, that you always need to correlate your EEG findings with a good clinical assessment. I'll just end by acknowledging where I got a lot of my material from, as I said, from the EEG online team, which is the 6-month EEG online course you can find there, and also from a good friend and colleague from the Mayo Clinic, Dr. Isha Sneha. Thank you very much.
Excellent. I knew it. I'd mentioned that it was going to be an exciting evening, and that has been a very comprehensive talk. I'd like to invite questions, and I see a flurry of activities on the question and answer window. So I'm going to read that to you, Melody. First one is subclinical seizures versus non-convulsive NCSE. I think that means non-convulsive status epilepticus. And there's no question to it. Maybe they just want to ask, what are those? What's the difference?
Okay. Thank you. Let me see. Can I share this again? Thank you so much, Sam. Yeah, so that's a good question, and that's also what I tried to emphasize is that there are always these differences um, that we deal with, but in the end, it may not necessarily change how we're managing the patient because, so I just want to go to the official definition here. There. Yeah, so there's two things here, is that someone can have a seizure and someone can have status epilepticus. So it's the same even with convulsive seizures. So you can have a generalized tonic-clonic seizure, which is time limited and it goes away, or you can be in status epilepticus, meaning the seizure persists and it lasts more than 5 minutes. So it's the same with subclinical seizures. You can have a subclinical seizure or you can have non-convulsive status epilepticus, which is also subclinical status epilepticus. So if you've got, because a subclinical seizure can only be diagnosed on EEG. So if you've got this EEG activity, which lasts for more than 10 seconds, but less than 10 minutes, then we'll call it a seizure. However, if this seizure activity is lasting more than 10 continuous minutes, or if you have recorded for an hour, and in that hour, 20% of the record is seizure activity, and 20% is roughly 12 minutes. So if the total number of seizures lasts more than 12 minutes, then we say the person is in status epilepticus. So essentially, they are having continuous seizures that are not aborting, as per the definition of the ILAE, as opposed to they could have one or two seizures, just like in convulsive. So that's really the big difference. The subclinical seizures are time limited, they are not continuous. Non-convulsive status epilepticus is continuous seizure activity. I hope that helps differentiate. So we should just think about it in the same way we think about a generalized tonic-clonic seizure or generalized convulsive status epilepticus.
Great. Um, you've got 9 more questions, so you'll have to run through those a bit promptly. So the
Let me
second is
think.
EEG reactivity. Is it within 2 to 3 seconds or longer? Is it any increase or decrease in voltage or frequency? Please clarify details.
Sorry, let me. EG, is it within?
Yeah, EEG reactivity, is it within 2 to 3 seconds or longer? Is it any increase or decrease in voltage or frequency?
Okay, so the duration is, to be honest, is not very clearly defined. But yeah, it's essentially within a few seconds. I would say you should see a response within less than 5 seconds, but I'm not sure that they've given like a specific time, but there should be a response within a few seconds. And it's often a decrease in voltage, but it's an increase in frequency. So for example, if you've got a theta background, and then you stimulate the patient, you would expect that their rhythm will become faster and it will attenuate. So the voltage or the amplitude becomes smaller, but the rhythms become faster. That's what referred to as reactivity. If we're talking, so, and reactivity again will of course depend in what context. So if we're talking about reactive alpha, for example, which is normal, when you're sleeping or you're awake but eyes closed and calm, you have a good alpha rhythm, which can be medium to high voltage. When you open your eyes, that attenuates. So it doesn't necessarily slow down or speed up, but the voltage reduces, and that's what we call reactive alpha. When we're talking about reactivity in encephalopathy, it means you've got theta or delta, similar with drowsiness. And then if you wake up the patient, we now see alpha coming through. So that reactivity is an increase in frequency. So it depends in what context. So in encephalopathy, you're looking for speeding up, and often still with a reduction in voltage. in normal alpha, you're looking at a reduction in voltage.
Okay, great. The next question is, what is evident in EEG in case of autoimmune epilepsy? I know you did indicate you're not going to
Mm,
address yourself to epilepsy necessarily. Maybe
mm.
this is also about autoimmune encephalopathy. Do you want to answer
Yeah,
that?
thanks. Yeah, so maybe I can speak about autoimmune encephalitis, which will be more related to this talk because autoimmune epilepsy will be like a whole other area. But in autoimmune encephalitis, typically it can have non-specific abnormalities, which is generalized slowing. They can be seizures, but there are some features, particularly in one type of autoimmune encephalitis, the NMDA encephalitis, where you see a feature which is called extreme delta brush. So this is where you've got delta slowing, and on top of the delta, there is this fast beta activity. So it almost looks like a little brush on the slow waves. And so extreme delta brush is thought to be characteristic of NMD encephalitis, although it may occur in others as well. But generally, like I mentioned previously, encephalitis can present in many different ways. In herpes encephalitis, for example, you have those lateralized periodic discharges. So it's quite variable, but some can give us clues, like the extreme delta brush for NMDA.
Great. Then, of course, there's a request for a link to the EEG course, which I guess is where your materials are from. We'll put that on the chat.
Yeah, we can just put the
The other,
website. Yeah.
yes. Then thanks for the excellent talk. And I want to say that there are many thank yous that have already been acknowledged. In newborn cases of brain death, in how many hours should you repeat an EEG to be in correct diagnosis?
Is newborn cases as in neonates?
I guess so. Um,
Okay. So, yeah, so
yeah, that,
mm,
go ahead.
do you want to comment on that?
No, it's just to say that EEG is not necessarily a requirement for brain death
Yeah,
determination by itself,
exactly.
isn't it? Uh,
Exactly. Yeah. So for many centers, I think, and I started by that, is like there's controversy even should you use an EEG at all. So what we discussed here is when you do use an EEG, and you can see it has to be very rigorous when you do use one. And so many times we really just rely on the clinical assessment of brain death. One thing I did say though is that if you've got severe encephalopathy like suppression or worrying about brain death, in adults, the time when we repeat, it tends to be shorter, 6 to 12 hours. But in neonates and children, because there's still a chance of recovery, it has to be at least 24 hours. So maybe to that question, if you were thinking, I'm not sure I need to repeat, then you need to wait 24 hours in neonates.
Great. Then there is thanks for the lecture. Could we, come on, what has happened here?
Mm, okay, I can see.
Could we differentiate which type of myoclonus, the type of myoclonus in a patient with coma, whether it's cortical, midbrain structure, or spinal myoclonus? Um,
Yeah, thanks. So I think that's a bit difficult. What I can say, when we think about EEG, there's still a lot of controversy if something like spinal myoclonus actually exists. And so in the EEG circles, we mostly think about EEG being cortical, and I mean myoclonus being cortical. And so when there's other types of myoclonic movements, those might actually be reflected as a movement artifact rather than necessarily a cortical abnormality. And so again, when going into those details, there's several characteristics, there's time duration for us to say this is truly a myoclonic EEG pattern. And it also has to be quite time locked with the clinical picture. So I'm not sure. The simple answer I would say is um, below the brain stem and the spine, they are not thought to generate um, a cortical abnormality. And so cortical abnormality that looks like myoclonus is thought to be cortical, if that makes some sense.
Great. Next is two questions. How do you manage EEG in ICU, considering sedative drugs that may impact the recording? And number two is there some disagreements regarding triphasic wave and their possible epileptic value. Can reactivity or response to, I think, benzodiazepine or anti-seizure medication help define etiology, or rather the implications?
Okay, thank you so much. Yeah, I mean, this talk, of course, had to be quite limited in EEG characteristics, and so we didn't delve too much into managing the EEG. Um, so regarding sedative drugs, so unfortunately, Nada, I mean, that is quite a difficult thing to say, but it depends what exactly you are managing. So it depends if you are looking at it from the aspect of seizures or if you are looking at it from the aspect of assessing a degree of encephalopathy. But generally, one thing that is done, especially if, say, someone was in status and they were on sedatives, there is a role of trying to withdraw the sedative medication and then assessing the EEG. As well, it's important to note, as I mentioned, there can be many reasons why an EEG is suppressed. So if someone has very deranged sodium, for example, or hypoglycemia or hypoxemia, you have to put it into the context that there are factors that are driving that abnormality. Many times we see patients in ICU with abnormal EEGs. These are patients who have no sedative. So these have been withdrawn, and you have to take into account the duration of action of these sedatives. So, for example, people who've been given phenobarbital IV for status epilepticus, the effects of this phenobarbital on the EEG and on the patient can last even 2 to 3 days. And so you have to put that into context. As opposed to something shorter acting like propofol, if withdrawn, the effects will wear off much quicker. So that has to be taken into account as you make your clinical decisions. And it will then depend, what are you seeing? Are you now seeing seizures coming up that you reduce the sedation? Are you seeing myoclonus in the context of cardiac arrest? It really has to go together with your clinical picture. Um, I can't remember the other question.
The other question was the implication of triphasic
Oh, yes, yes. Okay, yeah,
waves.
thank you. So yeah, that is indeed there is some uncertainty about what triphasic waves mean. And I think I also slightly touched on this, is that there are features that may worry us that these are not just triphasic waves. So for example, if they are quite lateralized, because triphasic waves are typically seen in a generalized toxic metabolic encephalopathy, so the whole brain is affected. But if I see triphasic waves localized to one area of the brain, if I see the triphasic waves seem to be having an evolving pattern, those components seem to be sharper, they seem to become more like bursts of epileptiform activity, they might be thought to be epileptiform. So if it's in the context of it's generalized, they fit the morphology, less worrying, as opposed to if there are some of those features that make them more worrying. What I didn't go into in this talk as well, because I was trying to keep it relatively um, understandable for all of us, is that with all these abnormalities, there's also what are called modifiers. So there's certain aspects that might come in that might make you worry more or push those abnormalities more to the seizure side than to the non-seizure side. So
Then how,
definitely, yeah,
yeah, great. Thank you for your
artifacts.
lecture. How do you manage artifacts in intensive care unit for EEG recording in your practice?
Um, this is very challenging, definitely. And it's one thing is managing, and the other thing is also just looking out for them, because there are times when you do your best. So when you are by the patient's bedside, you make sure that the grounding is good. You make sure that whatever machines or things that are not needed can be temporarily switched off, because things like infusion pumps will give you artifact. If there's monitors that are going on, it will give you artifact. But many times you find that you can't turn those things off. And so you just have to really be looking out for them. And looking at artifacts, that's also, again, another talk in itself. So when we start reading an EEG from the ICU, the first thing we do is just try to recognize as much artifact as we can. And this is where it's also very key to have a really good technologist or technician who documents everything that was surrounding the patient at the time. There was a cardiac monitor, there was an infusion pump, so that you don't end up recording things abnormally. Because just a drip, drip, drip can give you what can look like a rhythmic pattern, for example. So good grounding, make sure that the electrodes are tightly placed on the scalp. Test each electrode before you start, but then as well, good documentation from the technician.
And I'll add separating power sources if possible.
Yes, thank you.
Then, of course, thank you for a brilliant presentation, the anterior-posterior gradient when it is established in the pediatric population, and is it used to evaluate coma in adults?
Oh, thanks, Dr. Gwen. You probably know that better than me, being a pediatric neurologist. As you know, I'm an adult neurologist. So I mean, what I do know, what I can speak to is when is at the alpha rhythm more established, and that would be after the age of 2. And so perhaps after the age of 2, we start seeing more of that gradient, but still, even up to the age of 7, 8, we can still see quite a bit of theta, which can be considered normal. But the anterior posterior gradient, I think, is good in more developed brains, so in adults. But I would think, and I'm not saying this is like correct, I'm just kind of deducing. I would think after the age of 2, we might start seeing a better gradient. But you can advise maybe if you know better.
Okay. Then you have what aspects of EEG of anoxia brain in a patient comatose? I think the question is, what would you see in the EEG of a comatose patient who suffered anoxic injury?
Okay, thank you. So the main things, what I alluded to earlier is often a burst suppression pattern. That might be one thing that you might see, or you might see just a very suppressed EEG. Again, anoxic injury, we have to remember it's variable. It depends on how bad the anoxia was. So for some, it might indeed just be a generalized background slowing. The more severe it is, we might see burst suppression pattern, and that often comes with anoxic myoclonus, or we might see just a flat or very suppressed EEG.
Can a subclinical seizure be recognized without an EEG?
Um, yes, it can, but then there are many times when it can't. So we often suspect subclinical seizures. So the first time we suspect subclinical seizures is if someone presented with convulsive status epilepticus. So they were having convulsions. Now they are no longer having convulsions, but they are not waking up. That's our biggest suspicion that they have ongoing subclinical seizures. Again, any unexplained depressed level of consciousness. So you can't explain why someone is comatose based on their electrolytes, based on their brain imaging, their clinical exam. That's a suspicion. There are what we call subtle signs of subclinical seizures. And these can often just be, if you look at the pupils, you might notice that the pupil is very subtly constricting and dilating, and that's called hippus. So hippus could be a sign of a subclinical seizure. They could be just abnormal eye movements. The eyes are just roving, or there's nystagmoid movements, or there's this intermittent gaze deviation. The eyes look to one side and they come back to the midline. It might be just a very subtle finger, which is just twitching. So you look carefully at the patient. It could be just changes in their pulse. Pulse goes very high, then it comes very low. Saturations go very low, then they come. So such fluctuations could be clues that those could be subclinical seizures. But as I mentioned, the definite way is through EEG, but many times, like even at my hospital, many times we presume someone's having seizures based on some of these things that I've said.
Okay. What's the definition of intellectual discharge?
So an interictal discharge is a epileptiform or seizure-related discharge that happens when someone's not having a seizure. So ictus means seizure. So interictal just means the space when you're not having seizures. This talk was about coma, of course, so we didn't talk about epilepsy and seizures. But interictal epileptiform discharges have certain morphology and they are either called spikes, they are called sharp waves, or they are called spike and slow wave, or spike or sharp and slow wave. So they have a certain way they look. I did show on one instance the spike and slow wave discharges. So when those are happening every now and again, and they are not meeting the criteria of an active seizure, we call them interictal epileptiform discharges.
Okay. How are AEDs helpful in structural GPADs in EEG?
So this is, yeah, this is where it's very tricky. In that, as I mentioned, when we see generalized periodic discharges or when we see lateralized periodic discharges, those are not seizures. And so I say it's tricky because that's where some people are like, look, this patient has this focal brain abnormality, but they are not having seizures. However, because they have quite a destructive brain abnormality, they are at risk of having seizures. So guidelines say, though, that if someone has these discharges, but you haven't had a clinical seizure, you haven't had an electrographic or electroclinical seizure, then you don't treat them as seizures. But then others might feel like, especially in many of our centers where we don't have the luxury of continuous EEG to truly say this person won't get seizures. So many times we'll find that if we find this patient has lateralized periodic discharges, generalized periodic discharges, and they are comatose, we may treat them with anti-seizure medication just because we feel that they have a risk for seizures and we won't be able to catch those seizures. However, in the context where you do have them on continuous EEG monitoring and or they have a GPDs, LPDs, and they are not fulfilling the seizure criteria, then there is no role to treat them with anti-seizure medication.
Okay. For non-convulsive status epilepticus, what's the minimum duration for which you should take an EEG?
So if I showed you that, that was where we talked about that 2 helps 2B score. So based on that score, it was recommended an hour. And even on this, the definition by the ACNS of what characterizes an electrographic status epilepticus or electroclinical status epilepticus, that's essentially the same as saying non-convulsive status epilepticus. You should have a recording of at least an hour. If you have seizure, say you record for 20 minutes and you've got continuous seizure activity for 10 minutes of that 20 minutes, then that's non-convulsive status. So it's either you can demonstrate that seizure activity is going for more than 10 minutes, or if you recorded for an hour, you can demonstrate that of that hour, 12 minutes is seizure activity, then we call it non-convulsive status. So you need at least an hour, but it can be shorter.
Okay. Can you add the definition of alpha coma and spindle coma and CAP?
Okay, thank you. Yeah, so again, many things that I thought not to delve into um, in this talk, just because I was trying to make it pretty inclusive. So alpha coma, spindle coma, these are EEG patterns where in alpha coma, what you have is alpha rhythm. So it will be frequencies that's between 8 to 13 hertz, and it can look normal. But the characteristic thing here is firstly, the person is in a coma. So that's a clinical issue. And then secondly, it's unreactive alpha. So this alpha is there. Oh, looks nice. But you stimulate the patient, touched verbal stimulation, pain stimulation, and it just stays like that. There is no clinical response, there is no electrographic response. That's alpha coma. So it's in a similar way with spindle coma, is that they look like spindles and it's unreactive. So it's a comatose patient with that EEG pattern, which is unreactive. I'm not sure what CAP is though.
Neither. Um, Maybe they can qualify that. But the next question is, in birds, is patient having clinical seizures?
So again, these are features, these are electrographic features. So remember that if someone's having clinical seizures, they're having clinical seizures. Like the EEG will support our diagnosis of seizures, but if you've made a clinical diagnosis of seizure, that's what it is. Um, of course, with caveats, but I'm saying if it's a seizure that you feel is clearly defined and whether they are, if they're on the EEG, then they come together. Birds are not thought to be seizures. They fall into what's called that icto-intericto continuum, so the space between no seizure to seizure, but they are thought to be highly associated with a risk for seizure. So if you see birds, which are the brief, potentially ictorhythmic delta activity or discharges, then you will think that this person has a risk for seizure. But in itself, birds are not seizures.
Okay. Is there a standardized manner by which we can convey the severity of encephalopathy to our non-neuro colleagues, I guess based on EEG? A Sinex scale maybe, or any other method you may use?
Yeah, so for many of us, we do recognize that the EEG reports we send out are not to neurologists, and often they could even be either to general practitioners or medical assistants. So we tend to just use terms like mild, moderate, or severe. So we look at the EEG depending on the frequency, depending on the persistence, the reactivity, those factors I talked about. And then we'll tell the people we think this is a mild generalized encephalopathy or this is a moderate focal encephalopathy. And I often will go on to classify or to clarify saying if it's a mild generalized encephalopathy, this could be because of a post-ictal state, or it could be because of drugs or metabolic derangements, depending on what history I've been given. So it's always important you also get that history. Sometimes they'll tell you this was a person who was binge drinking and found unconscious, came in with a blood sugar of 1 millimole per liter. And so then you would say there's a severe encephalopathy and this is likely due to neuroglycopenic injury. So we use mild, moderate, and severe. I agree the scoring is helpful, but those scores are not known by our non-neurology colleagues. And so we tend to just in simple English explain. If it's a focal abnormality, we'll say there's a non-specific focal dysfunction. So this suggests there must be an underlying focal lesion. It doesn't show epileptiform activity, but the fact that there is this focal abnormality does increase their risk. And so correlate clinically. If this is someone who presented with seizures, they have this focal abnormality, then you probably may want to investigate that further, and they may still be at risk for seizures. So we essentially use descriptive terms in describing severity.
Good. Is it possible to differentiate between an isoelectric EEG outcome and a suppression caused by metabolic factors?
Uh, I'm not sure I understand what that means. Because aren't they both saying suppression? I'm not sure what they mean. Or do they just mean between determining like if it's metabolic factors or brain death, for example? Because
Uh,
if that's the case, as we saw on the standards for determining brain death, you need to have looked at all those other factors and confirmed that they have been corrected or reversed. Um, but of course, yeah, that's why the EEG really just supports your clinical assessment. because someone who's got very bad metabolic derangement might then pass away or demise. And so you need to look at it in that context. Were those things corrected, or were those things, and is there a possibility of giving it more time and so on? So it's not very straightforward. And you can't use the EEG alone. It has to be together with your clinical assessment.
Great. Maybe I follow up that with my own question.
Mm.
Does transient attenuation after an electrographic seizure stand distinct from a burst suppression?
Um, so like do you mean it suppresses then there's activity again, or?
You've got electrographic episodes with
Uh-huh.
follow-up attenuation. Um, would you classify that as a burst suppression?
Not just on its own.
Mhm.
So because with burst suppression, you really need to have periods of suppression followed by activity. So it should be suppression activity, suppression activity. But if it's just attenuation, that is actually typically seen, is that after a seizure, you see some attenuation, then some slow background, then normal background starts coming back. I think the thing to note, which again was beyond the scope of this, is that you can also have what's called electrodecremental seizures, where the suppression in itself is a type of seizure. But that is something as well like to discuss later. But yeah, if you have seizure attenuation, then slowly normal activity coming in, then that's not burst suppression. Burst suppression should be a burst and of usually what looks like a platform activity, few seconds, suppression, burst again for it to meet the pattern.
Happy. LPD at 1 Hz in encephalitis, will you give diazepam or just indicate cortical dysfunction? Wait LPD to 2 Hz to give diazepam.
Um, yeah, so if you're saying LPD, then you're saying LPD. So if you're saying LPD, meaning it's less than 2.5 hertz, so you have less than two and a half of those waves per second, then you're not calling them epileptiform, and so you won't give diazepam. However, if there is more than 2 per second, so 3 in a second or 4, then that's now fitting the criteria of seizure and you would give. So in these patients, I wouldn't give diazepam, but I would probably put them on an anti-seizure prophylaxis. Like I would give them, and I would prefer a non-sedating medication. So for example, I would put them on levetiracetam or I'll put them on sodium valproate. But just to note that I'm doing this more as to prevent seizures and not necessarily treating the LPDs.
Okay. Information regarding the EEG online, that's already on the chat. How about alpha coma, beta coma? What do they look like? We've
I
spoken to
talked
that.
yeah, about that.
Is there a standardized method to apply the intense somatosensory audio-visual stimulation to assess the activity that the ACNS electrocerebral inactivity protocol requires?
So I don't think they put clear standards, but I think there is literature that you can look into. But it's things like visual stimulation, they do suggest using like photic stimulator. For painful stimulation, there's different methods. I think there's like a sternal rub, there's rubbing on the upper brow of the eyelid, then you can like try and do sound like a loud clap and stuff. Whether there are particular um, procedures given, I'm not too sure. I would have to check myself. But in the guideline I read, it just stated it like that rather than giving examples. Except for visual, it did mention the photic stimulator.
Okay. In reference to the Zambian study, about 30% of unconscious patients had ongoing seizures. Is there a role for starting AEDs and seizure medication blindly in places where EEG is not available?
Thanks, Dr. Kaleji, for that question. And I think you you will agree, because we are from the same hospital, Dr. Kaleji, that we often do that. At our center, at least at the moment, we only have access to routine EEGs, and this is during working hours. And so if I have a patient that I'm quite concerned about, as I mentioned, I don't know why they're unconscious, or I know they had a seizure and they remained unconscious, then I'm highly suspicious that they might be having seizures. And so I will often treat them, not, I won't give them diazepam, but will often give them a loading dose of a non-sedating anti-seizure medication and continue them on maintenance until either we get an EEG, or if we see a clinical response, then that helps. So it's using, again, as I said, what's available to us would be levetiracetam or sodium valproate. I would be wary to use phenobarbital, because I won't then know whether that's the sedation or not. Many times, unfortunately, we only have carbamazepine available, and so we may give patients empirically carbamazepine. So as long as you don't think there's some other contraindication why they should be given anti-seizure medication, and you don't know why they're unconscious, I think it's fair to give them anti-seizure medication empirically.
What about your experience with evoked potentials combined to EEG registration in order to clarify a doubtful diagnosis?
Thank you very much, Liana. I think there is a role for evoked potentials. I personally, unfortunately, don't have experience using evoked potentials, so I can't comment on that.
What can we expect future several days in adult patients with general suppression, EEG, and coma?
Is this like the prognosis, I guess?
I guess so. Outcome.
Yeah, so it's difficult to give numbers. One thing that's definitely said is that the prognosis depends on the cause. So someone who's had anoxic brain injury, that is, say, following a cardiac arrest, the prognosis is very poor. And very poor because it's really depending on, are we talking about outcome in a week or within months? But there's more likely to be demise. I would say less than 20% in those who've had anoxic brain injury will survive, as opposed to, say, maybe it was someone with a toxic encephalopathy. Once that is recovered, if it's like renal failure, hepatic failure, there's a better chance of recovery, or if it's from other drug effects. So the one with the worst prognosis really is when you've suffered a severe hypoxic brain injury, or even a severe neuroglycopenic injury, meaning long chronic or many hours, say, of hypoglycemia. The outcome is much poorer for those.
Yeah, then we have the last question. Does edema in the patient's brain do anything to the EEG pattern?
Okay, thank you very much. So there's two things. Firstly, there is edema outside the patient's brain. So if there is scalp edema, that will lower or attenuate your frequency. So that's something to watch out for, especially say in patients who have traumatic brain injury. They have very swollen head, and so the waveforms might be lower, and so you might need higher sensitivities to pick up those brain waves. Swelling of the brain itself is considered like a generalized dysfunction. And so what you will get is an encephalopathy. So a generalized background slowing. How bad it will be will depend on how bad the cerebral edema is. But typically you will get a generalized encephalopathy. If it's focal swelling, then you get a focal encephalopathy. And you may have epileptiform abnormalities. It depends on the patient.
Thank you very, very much, Melody. That was a great engagement. We've had that 6 more minutes of questions and answers, and you've not missed a bit. Thank you. I'd like to make an announcement about the Global Health in Epilepsy Project database, which provides a registry of existing epilepsy projects throughout Africa, the Eastern Mediterranean, as well as in other regions. It identifies information such as project location, institutional partners, project scope, funding sources, and volunteer needs. The database is quick and easy to complete. By submitting information on your project, you inform understanding of efforts that are occurring throughout the world to narrow the epilepsy treatment gap. The database will provide us with an opportunity to learn from others and to explore collaboration opportunities that might strengthen your own work as well as that of the sector. Furthermore, the database will allow people from different areas such as government, academia, non-profit, or philanthropy to learn more about existing efforts while offering a means to engage. So if you can, please link up with the link that has been provided and put in the details. And next slide, you will scan the QR code to receive your certificate. There's also a link on the chat box on how to get the certificate. Very great and engaged audience. Thank you so much. I promised you that this was going to be a great January evening, and it has been. Thank you very much, Melody. Thank you, Jess, for making
Thank you
everything
so much,
happen.
Sam, and thanks the ILAE for inviting me.
Good.
Okay.
We are done.
Awesome.